We tend to think of a medical diagnosis as this solid, certain thing, a fixed point. But what happens when it's not? We're going to dive into a medical case that starts with a really common problem, but its journey, well, it's going to challenge the very way we think about disease and certainty.
I mean, a headache, right? It's so common. Most of us would just grab a painkiller and get on with our day. But for one patient, this simple headache was really just the first chapter in a medical mystery that would unfold over years.
And right here, this is where the puzzle really begins. A routine scan, just to figure out the headaches, ends up showing something else entirely. An incidental finding, a tiny little spot. The big question was, what was that spot? And more importantly, what could it become?
All right, so let's go back to the very beginning. We're in part 1, the initial discovery and what seemed like a pretty straightforward diagnosis.
The patient was just 16 years old when an MRI found this tiny 5 mm lesion at the base of her skull, and it was found completely by chance while they were just looking into her headaches.
So the diagnosis she got was actually pretty reassuring. It sounds complicated. Echordosis fisilipara. But what it really means is something totally harmless, just a little leftover bit of tissue from when you're an embryo that isn't supposed to grow or cause any trouble at all.
And based on that, the plan was simple. No risky surgery, just watchful waiting. The message was crystal clear. It's benign, nothing to worry about. But this is where our story takes a really sharp turn. Because the thing that was supposed to be a harmless, static remnant, well, it wasn't. 4 years go by, she's 20 years old now, and the headaches are back. So they order a new scan, and it shows the lesion has grown. This is the moment everything changes. The diagnosis, the plan, the whole level of concern, it all just gets thrown into question. And this leads the patient to ask her doctors a question that really cuts right to the heart of this entire medical mystery. If it could grow, was it ever truly benign? And could a different decision 4 years earlier have changed everything? To understand the answer, we have to pause our patient's story for a minute and really dig into the science. Why is this diagnosis so incredibly tough? Well, it turns out we're dealing with a tale of 2 tumors that can look almost identical. So here is the absolute key point. Both the harmless remnant, now known as a benign notochordal cell tumor or BNCT, and its aggressive malignant counterpart, the chordoma, they come from the exact same embryonic cells. They are basically cellular cousins. And this slide just illustrates the problem for radiologists perfectly. I mean, look at the overlap here. On an MRI scan, both can be small. Both are bright on what's called a T2 sequence. And here's the real kicker. A low-grade chordoma can lack the classic red flags, like eroding bone, making it a near-perfect mimic of its benign cousin. The confusion doesn't stop with the scans. Even under a microscope, they're both made of the same big, bubbly cells, and the little clues that tell them apart can be impossible to see in a small biopsy. What this means is that in these borderline cases, the final call can come down to a pathologist's subjective judgment. It's a really tough call. So how do you solve a mystery when all the clues can point in 2 completely opposite directions? The answer isn't a better test, it's a better idea. It's about completely rethinking the diagnosis itself. This quote from the source material just sums it up perfectly. The old model, this simple black or white choice between completely benign and definitely malignant, it's just outdated. It doesn't actually reflect reality. So the new model gets rid of that binary choice. Instead of 2 separate dots, we now understand that these things exist on a spectrum. At one end, you have completely harmless tissue. At the other end, aggressive cancer. And right in between, there's this big gray area of low-grade tumors with uncertain potential. And this new understanding needs new language. The proposed term is benign appearing notochordal lesion. Yeah, it's a bit of a mouthful, but it's so much more honest. It describes what doctors see on the scan, something that looks benign without making a promise about its future that they just can't keep.
Okay, so why does this all matter? Because this new framework creates a completely new playbook for doctors and for patients when one of these spots gets found. So here's the new approach. First, you use the honest terminology. Second, instead of waiting a long time for a follow-up, you start active surveillance, getting another scan much sooner, at 6 months, to check for any growth. And third, and this is absolutely critical, you make decisions about what to do next as a team with the patient.
This means the decision to do surgery is no longer simple. It's a complex calculation, as you can see here. Doctors have to weigh everything: the tumor size, its growth rate, what the scan shows, the patient's age and symptoms, and, maybe most importantly, the patient's own preferences and values. What do they want?
Which brings us back to our patient. After her lesion grew, it was surgically removed, and the final pathology confirmed it was, in fact, a low-grade chordoma, smack dab in that gray area on the spectrum. Thankfully, the surgery was a complete success.
Her story just perfectly illustrates this new understanding, and it leaves us with a much bigger question. While this case is about one specific tumor, the whole idea of a spectrum of disease applies all across medicine. It pushes all of us, doctors and patients, to accept uncertainty, to communicate about it clearly, and to move away from easy labels. It's a shift toward a more nuanced and, ultimately, a more honest view of human health.